I'm Jessica MP with Thoracic Surgery. We're going to go over the setup for your chest tube and the atrium. So for starters, you always want to make sure that you have water in this chamber here. It's really important because this helps regulate the amount of suction that's being experienced by the patient in addition to this little dial here. So if you have orders that were to say -20 suction, you would have the orange here. We'll want to make sure this has water, which it doesn't. So we're going to need to fill it because it can be dangerous if there's no water on there, because the patient's lung will directly experience the suction from either the wall or the canister, wherever you hooked up. So you take this and you're going to put it through the port where normally you attach your suction tubing, and then you'll see that it's going to drain down here to the bottom, which is where we assess for an air leak, which we will go over later. Okay, so all of that is in, and then since it said on the order that it's supposed to be to suction, we're going to go ahead and we're going to put this below the level of the chest. So we're going to bring it down on the floor. We will at some point hook it up to the IV pole, so we'll do that in a second. But for it to be connected to suction, and I'm just going to bring this up so you guys can see it better, we're going to attach it to this port. Now we have to look though, now everything's connected, but this orange bellow is not out. So if it's not out, the suction isn't working. So we're going to go over to the wall here and turn our suction on. Now it's fine for the suction to be connected up through the canister and then to the wall, so that's okay. If you ever have to use this canister for something else, then you can use our little portable suction to switch the chest tube over to, which we'll show you in a little bit. When you put this to suction, make sure we're going to the regular suction and not to intermittent, because if we place it to intermittent, then we are not draining the chest appropriately. So we're going to go back over and look at our little chest tube to see if our bellow is out. So it is out, which means the suction's working. Hopefully we've never seen air leak like this, so we'll ignore that for now. So now that that's all set up, we're going to go ahead and attach this to the IV pole. And we do that so it makes it easier for the patients to walk, and so the atrium does not get knocked over. So you would basically put it here, and we're going to tape normally around the foot here once and around the handle once, and I'm just not going to do that so we can still use this for teaching. But yeah, just a stripe of tape here and here, just so it feels secure. And then that's it for that. So we'll pretend that's attached, and then we want to look at our incision site. So let's pretend this is just coming out of the skin and that there's no dressing, so we'd want to dress it. So we like to keep it pretty minimal. So something to point out is that right now the tube is going posteriorly, which means that the patient were to sleep at night and roll, it's more likely to kink off. And that's basically the same thing as clamping a chest tube or removing it. So we don't want that. So to help prevent it, we're going to want our tube to go anteriorly. So we would kind of redirect it and then put just 2 4x4s under, 2 on top, and then just place a minimal amount of tape because we don't want to cause any like blisters and things on the skin. Alright, so I think that's about it for our chest tube setup.